Hello dear students, so we can start the session. The very first question is about entities, like all of the following are cyanotic heart diseases except. So you have to identify which one is not the cyanotic heart disease. And yes, it's quite easy, patent ductus arteriosus. Now here cyanotic heart diseases means which type of shunt? This is right to left. So a very easy way to remember, like if you see any condition, if it is starting with the C, this just for help, not the perfect rule. So that way you can think like it might be a cyanotic heart disease. Now in PDA, initially it is left to right. So initially it is left to right shunt, but if it is prolonged, then maybe at a later date it becomes reversed and then it becomes a right to left shunt, right? So whenever there is increase in the pulmonary pressure, that is pulmonary hypertension, and it can lead to reversal of the shunt, and that is known as reversal of PDA or the reversal of shunt, and in that case it becomes right to left shunt and patient will develop cyanosis. Now the point is that this cyanosis is present only in lower limb. So the cyanosis is present only in the lower limb and the upper limbs are not cyanosed. It is the only lower limb which will show cyanosis, and this is known as differential cyanosis. This is very important. This is known as differential. Yeah. So differential cyanosis, yes, very good, Raghu. So this is differential cyanosis only for lower limb and not seen in upper limb. Now just few more words about PDA. Now in fact we can take the ductus arteriosus first. So whether we will go with ductus arteriosus. Now ductus arteriosus is a very important structure in fetal life. What is the function of ductus arteriosus? Anyone? What is the function of ductus arteriosus in fetal life? See what happens, whatever the blood is coming into the fetal circulation, that is coming from mother. That is all maternal. This is already oxygenated, and moreover there is no fetal pulmonary physiology. So whatever the blood is reaching up to the right side of the heart, it bypasses through the PDA, like through the pulmonary trunk, ductus arteriosus to the arch of aorta. So rather than going into the pulmonary circulation, it is directly bypassing into the arch of aorta because it is already oxygenated. So this is in the fetal life. But once the baby is born and there is no source of maternal oxygenated blood, moreover the pulmonary physiology also starts. So now this ductus arteriosus has to close and the blood from pulmonary trunk should go to lungs proper for oxygenation, and from lungs it should come to the left side of the heart, and then to the left ventricle to the aorta. So the ductus arteriosus is very valuable in fetal life, but it is of no use in adult in a newborn. So once the baby is born, this ductus arteriosus should close. Okay. Now, in some babies, it fails to close, and then it is known as patent ductus arteriosus, especially in the one who are having congenital rubella. So if this ductus arteriosus remains patent, the entity is known as patent ductus arteriosus, right? So it is initially a left to right shunt, but with continued buildup of pressure in the pulmonary circulation, there is development of pulmonary hypertension, and finally it reverses, it becomes a right to left shunt, leading to differential cyanosis. Right? So this is in short about patent ductus arteriosus. Now let us move to the next question. A 3-year-old boy, now this is age is very important here, he stays alone, speech is delayed, but rest of the developmental milestones are normal. What can be the most likely diagnosis? I think this is pretty easy. I think this is classical case of autism. So in autism, there is lack of reciprocal social interaction. Clear? So this means that the patient is not very much interested in making friends, or neither he will respond to the whatever anyone, if someone wishes him or if he talks to him, he doesn't seem interested. So there is no reciprocal social interaction. Of course, there is delay in speech. Then characteristically, the onset is around 2.5 years and especially affects the male child, right? So this is a classical autism, and moreover he loves to play with inanimate objects, so like toys, books. Rather than making friends, he prefers to play with toys. So this is classical autism. We will discuss more in psychiatry about this, but for the time being, remember this much. So this is classical autism. Now, why it is not ADHD? Because here, if you see in HDHD, there are two things. One is attention deficit, right? So there are two terms. One is attention deficit and second is hyperactivity. So in attention deficit, you can say like the child is, whenever he is in the school, he will roam in the class, he will disturb other students, he won't sit at one place, he will not finish one work and then he will jump onto another thing. So there is impulsivity as well. So ADHD is different. This is classical autism. No hyperactivity. Yeah. Next question. A child with diarrhea was brought with sunken eyes and he is eager to drink on offering water, and skin pinch goes back slowly. Now this is what? Okay, this is which type of dehydration? This is which type of dehydration? This is which type of dehydration? Very good, moderate. And yes, for moderate dehydration, the color coding is yellow, right? Like here, the child is eager to drink. If you offer him water, he will drink. Eyes are sunken and skin pinch goes back slowly. So this is all moderate dehydration. Now next question. A neonate was brought with a history of frothiness from mouth and respiratory distress. What could be the diagnosis? Anyone? Frothiness from mouth and respiratory distress. This question we have already discussed, but the framing was little different. Yes, Raghu, you are right. This is trachoesophageal fistula. Very good. So the trachoesophageal fistula. You can see there is esophageal component, and there is, you can say this is tracheal component, tracheal complaints, right? So this is trachoesophageal fistula, frothiness and respiratory distress. Next question. A 5-year-old child with edema for last few months. It started on face, but now it is generalized with pedal edema as well as ascites. Good response to steroids. RBS is 112. There is massive proteinuria and nothing seen on CT scan, but electron microscopy showed effacement of podocytes. I think it is very easy to diagnose, a classical description for minimal change disease. So, classical description for minimal change disease, you can say good response to steroid, periorbital or facial puffiness, right? There is massive proteinuria and effacement of podocyte. All these features for minimal change. Now, next question: at what age handedness get established? Whether the child is right-handed or left-handed. Yes, it is around 3 years. Right? So this is around 3 years. So there are many things which develops around 3 years. Not only handedness, the child is also able to know his gender. Yes, 3 years. So there is a mnemonic for this. So you can remember, it will be very good. Like handedness for this thing, and then gender identification. This is very important. Then dressing, undressing, and apart from that, he can also draw a circle. That is also at 3 years. So these three are important: handedness, gender, and gender identification, and dressing and undressing by himself, drawing a circle. These are all at 3 years. Now, which of the following reflex appears first in a child? Yes, Patusha, the triangle at 5 years. So here you can also like triangle 4 years and triangle, remember, like 3, 4, 5. Very good. The earliest one is palmar grasp, and palmar grasp actually develops during intrauterine gestation. And what actually is palmar grasp? If you touch the palm with some object or finger, there is flexion of fingers, and the baby will hold that thing, whatever it is, object or finger, whatever. So this is palmar grasp. For a 3-year-old male child, the weight for height is 65% and height for age is 82% of the expected. Now, what this child will be labeled as? Weight for height is also less and height for age is also less. Yes. So weight for height, this is wasting, and height for age, this is. So this will be known as wasted and stunted. Yes, right. So weight for height is wasting, and height for age, if it is low, it suggests stunting. So wasting and stunting. Now, For a 2-year-old child, the height for the weight for height is less than 3 standard deviations as per WHO chart, and mid upper arm circumference is less than 11 cm. Now, what will be the diagnosis? If mid upper arm circumference is less than 11.5 centimeter, yes, that will be known as severe acute malnutrition. Very good. Here, so this is severe acute malnutrition. Right. What is the cause for marasmus? There is low intake of marasmus is because of low intake of, very good. So low intake of calories, and the child has a old man look facies. Old man look facies. Right. A 5-year-old child is brought after a crushing injury. ECG shows peaked T waves, prolonged PR interval, and wide QRS complex. What should be given immediately? Yes, so the clinical diagnosis is hyperkalemia. Very good. This is hyperkalemia, a classical tall peaked T waves. So we need to give insulin infusion because this will promote intracellular movement of calcium. But again, the possibility of or the tendencies of hypoglycemia, so it should be along with dextrose. Clear? Insulin with dextrose. Otherwise, the child will go into hypoglycemia. Yes, Pratyusha. Right? So I think this is clear, and this is I have repeated once again for hyperkalemia. And this is a classical ECG of hyperkalemia. You can see the tall peaked T waves. Right? These are the elongated. You can easily identify this in a case of hyper, right? Tall tented. Now, what is for Kwashiorkor? Less protein intake. Yes, very good. Now, for Kwashiorkor, you need to remember few points. There is, number one, there is edema. Now, these are some, yes, very good. See, these are some differentiating points from marasmus. There is edema, yes, flaky paint, dermatosis. What else? Edema is okay, flaky paint, dermatitis, yes. There is one important sign in here, and that is flag sign. Right? Flag sign of hair. And what happens? There are period of good nutrition followed by bad nutrition and then good nutrition. So there is patch of poor color in the hairs, and that is known as flag sign. So that suggests a period of alternate period of good and poor nutrition. And then what in liver? There can be mental changes in the form of apathy. What in liver? Any idea? In liver? The hepato. Here. So these are few important points for Kwashiorkor. Please remember. Moving forward to next question. After snake bite, there is petechiae. and ecchymosis on the skin. So yes, you can write fatty liver. So there is atiki, ecchymosis, and there is bleeding from the venipuncture site along with oliguria. So if you see here, all the features are suggestive of hemolytic toxin. This is, yes, Viper. So you can just have just a summary of toxins, snake bite. So Viper is hemotoxic, and cobra bait, that is neurotoxic. We have already discussed about the sea snake venom, which is myotoxic. Now, next question. A 4-year child has been brought with malnutrition and edema. Right. So the moment you find the word edema, straightforward, you have to jump to Kwashiorkor. Clear? So malnutrition with edema, please mark Kwashiorkor. Right. So here you can see this is a classical case of marasmus. You can see the old man facies, loss of muscle mass, whereas a child with Kwashiorkor, you can see edematous with bulging abdomen. Next question. On routine newborn screening at 3rd day of life, the baby was found to have TSH level of 40. What should be done next? Because whenever a baby is born, we do cord blood TSH level estimate, right? And the normal value is taken to be somewhere around 25. Triple value is taken around 25, and all of you must agree, if there is increased TSH, it might give an indication as if there is what can be the problem? Congenital hypothyroidism. So in this particular case, what we do, we will repeat the thyroid profile around 1 week. Punit, you are absolutely right. We will repeat the thyroid profile after 1 week, and based on that, we can take the decision whether to start thyroxine or not. So we will not start the thyroxine immediately. We will wait for another. So we will not start the thyroxine immediately. We will wait for some more time. Just have one more test. Let it be confirmatory, and then we can start thyroxine. Now here, this is cretinism, right? Now why we are so much concerned about this thing? Because congenital hypothyroidism, it is one of the treatable causes of mental retardation. So if we diagnose it early, we can prevent that mental retardation thing, right? So the usual algorithm says that if you find cord blood TSH more than 25 milli-international units, and you have to wait for, you have to repeat after some time, and then if it is abnormal, then you can think of the possibility of cretinism. Now, just few words about clinical features of cretinism. Any idea what congenital hypothyroidism? What are the clinical features? If you look at the facies, child will have a, you can see open mouth, with large protruding tongue. So very easy to identify. You will see a child with open mouth and large tongue which is coming out through the mouth. So this is a classical presentation. Yes, tongue protrusion, absolutely right. Then if you look at anterior fontanelles, especially anterior fontanelle will be wide and open, right? Be wide and open. There might be delay of milestones and hypertonia. And if you take X-ray, suppose you are taking X-ray of shoulder, what you will see? You will see epiphyseal dysgenesis, especially in head of. So just remember these 3-4 points for cretinism, which is a treatable cause of mental retardation. So very easy to identify, and sometimes cretinism has to be differentiated from. What will come in the differential diagnosis? Just looking at the facies, you have to sometime differentiate it from down. So this is in short about congenital hypothyroidism. Once PYQ is also a case of mental retardation, so that can differential diagnosis, but this is just looking at the facies. Facies is somewhat confusing. No, so once the initial sample is showing high level of TSH, repeat it within a week and then decide whether to start thyroxine. Hypotonia can be there. Okay, so please remember this one. Now, a 2-year-old baby presented with recurrent episodes of UTI, and the mother said that there is poor urinary stream with dribbling of urine. Now, which investigation is advocated or preferred? Firstly, again, before jumping on to the investigation, you have to tell me the clinical diagnosis, because then only your answer would be more authentic. Yes, Pratyusha Gulshan, you are absolutely right, but tell me the condition first. Now see, there is poor urinary stream and there is dribbling of urine. Yes, Raghu, you are right. Very good. So here there is poor urinary stream. It means there is some obstruction to the free flow of urine, right? And that is usually posterior urethral valve. Now, sometimes PUV is also associated with PUR. PUR plus PUV. You can find both. So this is vesico-urethral reflex, and this is associated with posterior urethral valve. Both of these conditions, they coexist actually, and especially in cases of VUR, we will have urinary tract infections. So this is the classical, condition which is coming out from the clinical history. PUV plus VUR, and especially for PUV, we will go for micturating cystourethrophy, that is MCU. Absolutely, everyone is right. So only for UTI, urine culture is good, but you have to consider other options also, and that gives an impression as if the child is having posterior urethral valves. So here there are the valves, and this is preventing the free flow of. So posterior urethral valve, this is associated with VUR. Yes, Pratisha, right? And this predisposes to UTI. Clear? So this is poor urinary stream and dribbling of urine. This is the picture, and this is MCU demonstrating posterior urethral valve. So this is how you should tackle this question. Now next question. A 16-year-old child presented, and He hadn't attended Minarchy, female child. So she hadn't attended Minarchy, and the karyotype is 46XX. There is hypertension, and secondary sexual characters were also absent, most likely deficient enzyme. Now, of course, this is a case of, yes, congenital adrenal hyperplasia, right? But they are more interesting reaching up to the deficient enzyme, which now here you have to remember just two things and you will never be wrong in your answer. Number one, look at the phenotype. This is 46. Look at the karyotype. This is 46XX. So this is a female. Right? Then second is, see whether there is hypertension or not. If there is hypertension, then straightforward you have to mark your answer as 17 alpha hydroxylase. Yes, Raghu, you are absolutely right. If hypertension is there, 17 alpha hydroxylase deficiency in a female. Clear? So just look for these 2 points, whether patient is female or whether there is hypertension or not. Hypertension, female patient, go for 17 alpha hydroxylase. Just 2 points and you will never be wrong in your diagnosis, because what happens when there is 17 alpha hydroxylase deficiency, the aldosterone is formed normally. Right? Aldosterone is formed, okay, but there is no formation of, no synthesis of glucocorticoids and sex hormone, sex. Clear? Because this is the connecting link between, that is the initial starting point for the process of synthesis of glucocorticoids and sex system. So if this is deficient, these are not formed, only aldosterone will be formed. And I think most of you must be knowing what is the function of aldosterone. This is sodium, water, tension. And if you can recall the renal angiotensin aldosterone system, what we discussed in the second session, it is responsible for blood pressure. That way you can correlate that why we find hypertension in 17 alpha hydroxylase. Here, female hypertension, 17 alpha hydroxylase deficiency. So don't think too much. So this is the summary. Female BP high, female go for 17 alpha deficiency. Yeah, this is the simple thing. That way you will never be wrong. Now going to the next question. 5 years old male child was delivered normally without any congenital anomalies. Now is having 70% of the normal body weight for his age. He had a large and distended abdomen, dependent edema, and there is desquamation of skin with multiple areas of depigmentation or hyperpigmentation. I think everyone can answer it very perfectly. This is a case of Kwashiorkor. What points you need to note here? This is distended abdomen, right? There is edema, and this is flaky paint dermatosis. Flaky paint. Yeah. Classical case of Kwashiorkor. Yes, of course, edema I have already wrote. Edema is also. A child has ingested some unknown substance. Hepatomegaly is also. And there is excessive salivation, lacrimation, meiosis, GI cramps, and emesis. what substance has been ingested most likely? Yes, if you look at the presentation, this is cholinergic symptoms. Yeah. So this is carbamates. Yes, for cholinergic you have to give anticholinergic, that is atropine. Yes, organophosphate also will have the same presentation. Right. So this is carbamate. Now, which of the following is not associated with ASD? Yes, Mantis, you are absolutely right. Yes, because what condition is related to Turner syndrome? Aorta. Yeah. So this is coarctation of aorta, and what happens in coarctation of aorta? Yes, bicuspid aortic valves. That's also. So what happens in coarctation of aorta? Whose is left subclavian artery. And below this, there is narrowing, and this narrowing is known as coarctation of aorta. This is left subclavian. This is the area of coarctation. Now, what will happen? Now, these all vessels, they are taking the blood flow to the upper extremity and the head and neck area. But the blood flow to the lower limb, going through the descending aorta, yes, and abdominal aorta, this is reduced because of this coarctation. So, if you will measure blood pressure, what will happen? You measure blood pressure, what will happen? Very good. So, there is radiofemoral delay, yes. But if you take blood pressure, it will be high in upper limb and it will be low in, that will be the difference. And apart from that, because there is opening up of collaterals, there will be opening up of collaterals which will produce inferior surface or inferior border rib notching. Okay. So rib notching can be on the inferior border, please remember. So this is a little bit about coarctation of aorta, and this is one classical picture for extremity hypertension, lower extremity hypotension. There can be dizziness or other things. So please remember coarctation of aorta and relate it to Turner syndrome. I'm not going into the symptomatology of or other features of Turner syndrome as such. So I'm more concerned with the coarctation of aorta part here. This is classical picture of Turner syndrome, and you see coarctation of along with, as you can see, bicuspid. Thank you. Okay, let's move on to another question. 2 days old neonate with cyanosis, single heart sound, and pansystolic murmur on the left sternal border. ECG shows left axis deviation and left ventricular hypertrophy. What can be your diagnosis? Please read the words properly. 2 days old child, neonate, there is cyanosis, single heart sound, and left ventricular hypertrophy with a pansystolic murmur. What can be the presentation? So whenever we are saying cyanosis, it means the condition is what kind of shunt? Right to left shunt. Number one. When we are saying single second heart sound, if we are saying single second heart sound, means one of the component of the second heart sound is absent. So either A2 is absent or B2 is clear. So single second heart sound. Then third is pansystolic murmur. Third is pansystolic murmur throughout the systole. And this can be because of PSD. And then fourth is left ventricular hypertrophy. It means that is very well, left ventricular hypertrophy. This is because of this right to left shunt. So blood is going from right towards left side. Now in all these conditions, if you look properly, now what is TAPVC? Any idea what is TAPVC? In TAPVC, there is connection of pulmonary veins which are carrying oxygenated blood to either the bigger veins like superior vena cava. So this is actually left to right. Right? So this is left to right shunt. So this will definitely be ruled out here. So blood is going from pulmonary veins to the, that it can be draining into the superior vena cava or below. It can be supracardiac, intracardiac or infracardiac, right? So this is oblique. Then what is transposition of great arteries? Transposition of great arteries. Here the aorta is originating from right ventricle and pulmonary trunk is originating from left ventricle. So transposition of great arteries. Again, this is right to left shunt, but this again discuss other things like pansystolic murmur or single heart sound. Now in tricuspid atresia, what happens? The tricuspid valve is closed. So there is closure of tricuspid valve. Suppose if I draw the tricuspid valve, this is closed. This is closed tricuspid valve. Now what will happen? The blood which is coming into the right atrium, it has to go somewhere. So through ASD, here there is ASD, it will go into the left atrium. Yeah. And then through the left atrium to left ventricle, and lower down we have a VSD as well. Lower down we have a VSD as well, and through the VSD the blood will come into right ventricle, and then through the pulmonary valve it will go. But sometimes there is obliteration of pulmonary valve also, and that what it is leading to affection of the second heart sound. So considering this particular question, although this is a little complicated, tricuspid atresia becomes a better. Yeah. So because we can explain pansystolic murmur, we can explain the single heart sound for cyanosis and left ventricular hypertrophy. Now most of you must agree that which chamber hypertrophy is seen in tetralogy of Fallot? Any idea? Which chamber hypertrophy is seen? This is right ventricular hypertrophy. Clear? So that way, just this, because otherwise most of the things might confuse you. You can have a VSD giving rise to pansystolic murmur. You have pulmonary stenosis giving rise to affection of the pulmonary component of the second heart sound. But this particular word is totally against the clinical picture. Clear? So tricuspid atresia comes out to be a better answer considering this whole picture. Yes, this is a little tricky question, and you have to just join up the things in a proper way, then only you will reach up to the answer. So this is the way we find a case of tricuspid atresia. You can see that there is no tricuspid valve as such. So the blood is going from the right atrium, the left atrium, going this way, into the left atrium. Through the left atrium it comes into the left ventricle, and through the VSD it is coming to the right ventricle. And then there is affection of pulmonary valve also, which which affects the second heart sound. Clear? So this is tricuspid atresia. Next question. A 4-year-old child is admitted with fever, non-purulent conjunctivitis, rashes, cervical lymph node enlargement, hepatomegaly, desquamation of fingers and toes, and there are coronary artery aneurysm. Yes, this is a very classical picture for Kawasaki. Yes, so this is Kawasaki disease. Yes, strawberry tongue. Very good, very good. Strawberry tongue. And then, so this is classical picture of Kawasaki disease. Conjunctivitis, rashes, lymph node enlargement. Okay. So along with, yes, of course, fever has to be there. So if we take the diagnostic criteria for Kawasaki disease, fever has to be there, of course. And apart from this, either there has to be rash or strawberry tongue, lymph node enlargement, okay, conjunctivitis, or desquamation. So this is all classical, yes, more than 5 days fever. 5 days fever has to be there. So this is Kawasaki disease. Of course, this is very important here, strawberry tongue. Now, next question. A 7-year-old child presents with intermittent claudication, pain and weakness of leg, and dyspnea on exertion. There is delayed and weak femorals as compared to the brachial arteries, and there is a forcible left ventricular apex. Yes, we already discussed that classical case of coarctation of aorta. The classical picture you see here is radiofemoral or brachiofemoral. Yeah. And classical for coarctation of aorta. This we have already. Next question. If you want to close patent ductus arteriosus, what you will give? Closure of patent ductus arteriosus, ibuprofen, right? So we will give PGE1 antagonist, can give either indomethacin, can give dynamic ibuprofen. Yes, if you want to keep it patent, then obviously we have to give PGE1 analog containing NC, of course, alprost. Yeah. So this is for closure. This is for maintaining. Yes, alprost. Now, next question. A 3-year-old child is brought with sudden inability to walk following fever of 2 days duration. Sensorium is okay. Lower limbs are hypotonic, and this is asymmetric, right? Lower limb is affected more than left. Plantar reflex of no help and DT are not elicitable on both sides. What can be the diagnosis here? Especially in a child after fever, we have lower motor neuron kind of paralysis? Yes, the answer has to be acute poliomyelitis. Right? So, element kind of poliomyelitis. Fever, element, think of poliomyelitis. And this is actually acute flaccid paralysis. Acute flaccid paralysis. Now, which tumor presents as an abdominal mass in a 2-year-old child? In a 2-year-old child, very good. This is neuroblastoma, and we differentiate neuroblastoma from neuroblastoma has to be differentiated from. Yes, everyone is okay. Neuroblastoma. What comes in differential diagnosis of neuroblastoma? Anyone? It has to be differentiated from Wilms tumor. Very. We have to differentiate neuroblastoma from Wilms tumor. And any idea? What are the differences? This is most commonly seen in less than 2 years. This is somewhere around 5 years. Then both the conditions they present as abdominal mass, but this can cross midline. This doesn't cross midline. These are two important differences: age and whether, yes, both are abdominal mass, and therefore they comes in differential diagnosis. Na? So both as abdominal. Therefore, we have to differentiate what actually it could be. So Wilms tumor, that's nephroblastoma. Age is different, and Wilms tumor is usually onto one side. Neuroblastoma crosses midline. Very good. Just remember this much. Next question. A 6-year-old child is having crampy abdominal pain. So she is having crampy abdominal pain with rashes mainly over the back of leg, buttocks and extensor surface of forearm, and laboratory reveals proteinuria with microscopic hematuria. So here you have to consider two important points. One is abdominal pain and rashes, and then there is proteinuria with hematuria. So yes, this is small vessel vasculitis, and yes, this is Hinoch-Schönlein purpura. So this is Hinoch-Schönlein purpura, right? So abdominal pain, rashes, especially involving the lower limbs, and proteinuria, microscopic hematuria. This is Hinoch-Schönlein purpura, small vessel vasculitis. Now this is another question, and a child presents with Lisch nodules and capillary spots. Similar symptoms were also seen in father and grandmother. Now, what kind of inheritance is this? Understand? And here what we see, that every generation is affected. Right? Every generation is affected. So starting from grandmother, then father, and finally the child. So the disease is manifesting in every generation. Very good, Puneet. So this is a typical autosomal dominant. So I think autosomal dominant is the easiest one to identify, and if you have a pedigree like this, in which you can see in this generation, this one is here, this person is affected. In this generation again we can see that 3 persons are affected. Then third generation we can see 2 persons are affected, and in fourth generation we can see 1 person is affected. First generation, second generation, third generation, fourth generation. So if you see affection of all the generations, straightforward you can mark answer as autosomal dominant. Clear? Of course, the circle is for females and square is for males. Square is for males, circle is for females, and if the circle is colored or darkened, it means it is affected. If it is white, it is unaffected. Now the next question, and it's about a 5-year-old child who is having multiple episodes of hematemesis. Vitals are stable, spleen is enlarged. Now what can be your diagnosis? This question we have already discussed, and I just want to see whether you remember it or not. So hematemesis, splenomegaly, but vitals stable. In a child, this is suggestive of this is actually portal vein thrombosis, right? So this picture is portal vein thrombosis, and yes, Weber. And in a case of adult, if you have hematemesis plus splenomegaly, you have to think of esophageal varices. Here you will think of varices, which is because of here. So presentation somewhat similar, but diagnosis different as per the age. So this is portal vein thrombosis. So tertiary is hepatic vein thrombosis. So this is, you can see, this thrombosis in portal vein, and that leads to opening up of the anastomosis at the lower end of vagus. Right? So portal vein thrombosis, and again you can see there is enlargement of, this is the classical picture, portal vein thrombosis child. Now next question, a 7 days old child presents with vomiting and diarrhea. There is cataract in both the eyes. What can be the answer? There is vomiting and diarrhea, especially after breastfeeding, and there is cataract in the eyes. Yes, this is classical case of galactosemia, where we find oil drop cataract, and this is because of deposition of which substance? Because of deposition of lactylose. Yeah. So this is clear-cut galactosemia, and in galactosemia there is deficiency of galactose 1 phosphate uridyl transferase, and hence the galactose is not converted into glucose. So this is galactosemia. A 3-year-old child is brought with complaint of not being able to stand or walk, and even the head control is achieved at the age of 1 year. There is generalized hypotonia, but PTR, brisk, and ankle clonus. What is this picture? Here you can see there is head control, which should have come at the age of, you can say, 3 months, it came at 1 year. There is a component of upper motor neuron kind of entity with hypotonia, and this is very suggestive of the hypotonic cerebral palsy. This is hypotonic cerebral palsy. Tough question. So hypotonia with cerebral palsy, hypotonia plus human features. Okay, so hypotonic cerebral palsy. Now, next question. 4 years old child was a case of sickle cell anemia, and he is presenting with pain, swelling of bones, especially of the hand and feet, with severe pain in abdomen. There is necrosis of femoral head, but this resolved after 1 week. What can be the explanation to this? Especially in a case of sickle cell anemia, there are painful episodes. Very good, Dr. Antis, absolutely right. This is vaso-occlusive crisis. This is Pratyusha, yes, you are right. This is vaso-occlusive crisis, because what happens, this sickling of RBCs is not permanent, right? So this sickling of RBCs is not permanent. It comes after certain conditions, especially deoxygenation, or sometimes if there is any infection or even dehydration. So what will happen, these conditions, they will promote sickling. They will promote sickling, and what will happen, the RBCs, which are usually by concave disc, they will change their shape to crescent, something like this. Now these are bone pains. So these are like, they are bound to go, and they are bound to occlude the small arteries. So that what leads to vaso-occlusive crisis, and that presents as painful episodes with swelling, especially in the small bones, and this is known as bony pains. This is bony pains, and here you can also remember one more term, that is priapism. Priapism can also be related here, right? So this, and once the sickling goes away, condition will resolve. This is very important. And yes, there can be AVN of, there is possibility just because of this impairment of the arterial blood flow. So this is a classical vaso-occlusive crisis. You can see the sickled RBCs leading to vaso-occlusion. So vaso-occlusive crisis. Right. Next question. A child presented with complaints of fatigue. He was having an enlarged liver and spleen. There was anemia, and peripheral blood smear showed target. This is very easy. Yes, this is thalassemia. So you can see enlargement of spleen with anemia in a child and target cells on peripheral blood smear, that is thalassemia. So if you can see, these are the target cells. These are the target cells. Target cells, please remember it for thalassemia in a setting of anemia. A child is restless and agitated. He has stridor at rest and marked tachypnea. There was chest retraction. And what will be the classification of pneumonia? Yes, so there is chest retraction. This is severe pneumonia. Clear? Severe pneumonia. Severe pneumonia with especially with chest indrawing, very severe pneumonia. The child started choking at the dinner table and is not able to cough or speak. Now what he will do immediately? What he will do immediately if you see that there is food in the respiratory tract? Yes, give back blows. Very good. Give back blows to dislodge the food from the respiratory tract. Next question. 7-year-old girl with non-specific abdominal pain, little bit of distension and not growing well. For adults seem like yes. Systemic examination is normal. Hemoglobin is less and it suggested microcytic hyperchromic anemia which is not responding to iron therapy. What will be your first investigation for this condition? Now, this is little difficult. Yes, the answer is tissue transglutaminase antibodies. And why you will go for what condition are you suspecting? Condition is celiac 2, which at times may be associated with iron deficiency anemia. So there is a case of refractory kind of iron deficiency anemia. Think of the possibility of celiac sprue, especially if the patient is having GIT symptoms as well, right? So GIT symptoms or malabsorption symptoms with anemia, think of the possibility of celiac. Allergic to wheat and is not able to digest, and there is anti-endomysial bodies. What is the diagnosis? Yes, this is celiac sprue and anti-endomysial antibodies. Clear? A child has difficulty in passing meconium for 48 hours after birth. What should be done next? We have already discussed. Yes, go with barium enema. And the condition which we have already discussed is the area of aganglionosis and proximal dilatation. Yes, Hirschsprung disease. Okay. Start with enema. It is also next. Start with enema. Aganglionic megacolon. Then next question. A child is having diarrheal episodes and is lethargic and floppy, drinking poorly, and on pinching, skin goes back very slowly. Takes more than 3 seconds. Pulses are weak. So this is a case of severe dehydration. Here, classical floppy child and drinking water poorly and skin going very slowly. This is severe dehydration. If a child is irritable but is drinking water quickly, eyes are sunken, and on skin pinching it goes back slowly. What can we do? Yes, and what is the diagnosis here? Is moderate dehydration. Okay. For moderate dehydration, we have to give oral RS. Moderate dehydration. Child is accepting water, or you can say very eager to drink. Eager to drink. Now next question. A 5-year-old boy is brought with a crush injury. I think we have already discussed this. Peak T waves, give insulin with. We have already discussed. Now next question. A 6-year-old child with oliguria, hematuria, puffiness of face, convulsions, BP of 200, peak 100, and blood urea is high. What can be the answer here? Now, if you stick only to this point, you will be wrong in your diagnosis. You have to consider other options as well, like hematuria, then convulsions, raised blood pressure, right? So, oliguria as well. So, this goes more in favor of, no, this is a, this is nephritic syndrome kind of picture. There is some edema, hematuria. This is nephritic syndrome. And this is hypertension. This is involvement of nervous system. What you can think of now, considering these 3 points? Yes, it is AGN with hypertensive encephalopathy. Because hypertension, we know, this is also a feature of glomerulonephritis. Yeah. So this is glomerulonephritis picture, which is going into encephalopathy. So we have already discussed what we find in nephritic syndrome. Hematuria, right? Yeah. Edema, and hypertension. All this is AGN, nephritic syndrome. So this is acute glomerulonephritis with hypertensive encephalopathy. Clear? Now, 4 years old child with periorbital edema and foamy urine, severe proteinuria. This is a classical case of minimal change disease, and yes, you have to give steroids and it responds well to. Very good. What is the effect of vitamin A over formation of urinary stone? Vitamin A prevents formation of urinary stones. So there are 2 vitamins which you should remember in terms of urinary stones. One is vitamin A, will prevent desquamation or the formation of a nidus. So it will decrease. And which vitamin will increase? And therefore we tell the patient, please avoid this. Which vitamin will increase? Vitamin C. And therefore we tell the patient to avoid citrus fruits or stuff. Right? So vitamin A will prevent, and this will, yeah, just remember these 2 vitamins with respect to urinary stones. Now next question, a child with recurrent episodes of fast blinking followed by continuous staring, and the episodes usually last for 30 seconds with abrupt termination. EEG shows spike and wave pattern. Very good. And just because of these episodes, he is performing poor in school. Yes, so the answer is very good, Nidhi. This is a classical case of absence seizure. An absence seizure should be maintained by, should be treated by sodium valproate or ethosuximide. This is absence seizure, ethosuximide or valproate, whatever in the option. Fast blinking followed by continuous staring in spike and wave pattern on EEG. A child develops fever with rash, cough, conjunctivitis, and coryza. Measles, perfect. Coryza is running nose. This is all classical for measles. And what is the time of appearance of rash after fever? For how many days you will have rash? Rash. How many days gap? How many days gap between fever and rash? Okay. Max 4 days. So this ends the pediatric part.